Hi everyone, good afternoon. As Michaela has said, my name is Jenny and I am the Advocacy Officer at STOPAIDS, which is an NGO based in London. So I'd like to again take the opportunity to welcome everyone on behalf of all the organisations who have been involved in creating this event, and it really has been a collaboration between STOPAIDS, Results UK, MSF, ICSS, Aidsfonds, and the International HIV/AIDS Alliance. I hope that you'll benefit from all of our various organisations' expertise, connections and contacts, and kind of hearing about this from the speakers that we've brought together. So as I hope will be clear from the panel that you're about to hear from, we as organisations see transitions as a hugely complex and important issue which deserves more attention from the international community. And as we enter into a new era of development and a new era of the global economy, many donors are choosing to end programmes in countries where they have previously provided support. And this is happening at the same time that countries have made increasing commitments to the shared agenda of achieving UHC and also of leaving no one behind. So this event will seek and serve to tease out some of the implications of this new era, as Michaela alluded to, the roles and the responsibilities of different institutions in addressing and navigating those challenges, and also, of course, the impact of transition on the countries and communities experiencing these changes, which are taking place really as we speak. So I'm going to hand back to Michaela, who will be moderating to introduce our speakers up one by one. And once everyone's given their presentations, we'll have some time for Q&A from the audience as well. So I hope that while people are speaking, you'll be thinking about the questions that you have. Thank you.
Thank you, Jenny. So what I want to do actually, just to let you know a little bit about the format of this event. So we will have actually the different presentations first and then open up and have the panel discussion and open up for Q&A for you. So in that sense, I'll take one by one. I will not introduce all the speakers in all lengths because you do have actually the biographies of speakers which we have prepared for you. So I hope you have taken that from outside. So you do please read up because we do have actually distinguished guests here with a long history also in their fields. And I think worthwhile reading through their different experiences. But let me start now with Danny Graymore from DFID. Danny has been actually a long history also in access to medicines, has worked also on the role of the business, and we'll talk here now, though, around polio eradication and the polio transition plan. And for those who have been with us on the Sunday already, so a few days ago, have been through all the week here, did probably also listen to Ranieri Guerra from the WHO, who also spoke about polio transition and the challenges and the risks involved here. And very clearly, there are a number of risks in the transition process. We have not only the human resources, financial, programmatic risks, and also, of course, questions of ownership and also capacity, ultimately. So really also the question then to you, Danny, how does DFID handle that? I mean, what is your responsibility here as a donor? So if I may please ask you to come here and speak about that. Thank you.
Water. So, well, good afternoon, everyone. Thank you very much. Can I pop this down? I'm not going to upset anyone's IT by doing so, I hope. So thank you very much for inviting me to speak. It has indeed been, well, we are at the end of the week of WHA, and quite a number of people were around for PBAC at the end of last week, and a number of people are anticipating the executive board at the beginning of next week. So it's been a busy time, and I think it's been quite a long week, but it's been a really good week, actually. I think it's been a good WHA, and we've got some key areas of delivery through, including the really good discussions on polio. And I'm really glad to be here to talk about polio transition, but also part of a broader discussion on transition today, because I think it's the right theme. Transition is going to be an enormous issue across a whole range of funds and institutions and financing approaches going forwards. And it's going to be important to get it right, obviously. It's going to be important to get it right in a way that lays the foundation for stronger health systems, for better health financing, and for our collective goals towards 2030 and the SDGs. And we need to be very clear as we approach multiple set of transitions as to how we're going to do it and what the challenges really are. And if we get it right, of course, we're going to lock in what has been billions of dollars of investment in global health in the last 10, 20, 30 years. An enormous amount of that investment, of course, comes domestically from countries in low-income and lower-middle-income settings. But a significant amount also comes from donors. And we need to ensure that as we head towards 2030, our objectives around HIV, around TB, around polio and elsewhere are really going to be met, and that we achieve our targets towards the universal health coverage goals of the general programme of work. But there are, of course, risks, and we'll come to those in a minute. I'm going to speak about polio transition, but I'm going to first of all spend a moment sort of applauding polio success. I think everyone here knows the global polio eradication initiative. It was set up in 1988. At that time, 1,000 children a day were being paralysed from polio, 350,000 cases a year. Since that time, we've seen a 99.9% reduction in polio worldwide. It's an incredible achievement, and it represents a huge amount of financial investment, but a huge amount of people investment and country investment. And the assessment is that 16 million people are walking today who would not be, were it not for GPEI, and 1.5 million people are alive today. So sometimes we spend a lot of time thinking about where we get things wrong in international development. We need to remember where we can really come together as a global community to get things right, and this is a great example. Of course, that success means that we're coming towards the end of the programme of the Global Polio Eradication Initiative. A couple of years ago, a year ago or so, the UK, as one of the biggest donors, but the third largest donor to GPEI, made an additional commitment of £100 million on top of what has been over £1 billion of commitment from the UK since the GPEI was set up. And we made that £100 million commitment on the basis of achieving interruption of polio transmission by the beginning of last year, the beginning to the middle of last year. And that was at that time the sort of best estimate of what we were going to achieve. And of course, we haven't actually achieved interruption. And one of the key things as we talk a lot about transition has been to come back and say to ourselves, actually, let's not forget that the job has not actually been done. Although we've had this massive reduction in polio, we've had around 8 cases in Afghanistan and Pakistan between the two countries so far this year, and over 20 cases last year. A huge reduction, but there's a job yet to be done there. And of course, transition won't actually happen in terms of closing down the Global Polio Eradication Initiative until we have achieved interruption. So that's now going to be maybe the last case might be in a year or so if we're fortunate, and then we'll wait 3 years for certification to be confident that we've actually achieved interruption. So in that sense, the GPEI continues going forwards. Nonetheless, transition is very firmly on the horizon, partly in those countries that have already achieved interruption, which continue to receive quite a significant amount of support from the GPEI, and in partly in terms of anticipating the countries where we will achieve interruption. Now, I think people know that the Global Polio Eradication Initiative represents maybe 20% of WHO's overall global financing. It's a very significant amount of money. And in a number of countries, it represents over 50% of country office for WHO, country office activities, and in some countries around 70% or so. And beyond the polio work, the staff and the capacity at the country level has been critical in supporting broader routine immunisation and other health interventions, including, very importantly, on emergency response. And we all know that in Nigeria, the GPEI played a really important role in identifying Ebola coming across from elsewhere in West Africa and enabling a rapid response. And we've seen similar responses of GPEI people and capacity responding on yellow fever in DRC and elsewhere. So we know that actually in many countries, they're very dependent on the financing coming from GPEI. And so, of course, as we anticipate changes in that financing, we need to anticipate this transition issue that we're looking at. So getting transition right is going to be important. We have at least 3 sort of categories of country to think about as we move forward on this. And this is the work that Dr. Guerra has been setting out this week, of course, and the discussions that we've been having at places like the Polio Oversight Board. We have countries where we haven't actually seen interruption occur yet. So we've got northern Nigeria, and we've got the contiguous areas between Pakistan and Afghanistan where we continue to see cases. Northern Nigeria has not actually seen a case since late 2017 or so. But until we actually see 3 years pass, then we won't know that the cases have been interrupted. But also it's very hard, as people know, to actually get into the areas where polio continues to be endemic. And so confidence about interruption is really challenging. Afghanistan and Pakistan have continued cases arising this year, but a very limited number. So we have those countries, and we need to plan for that. And in all likelihood, that's a continuation of the Global Polio Eradication Initiative and see through the job, and that's the right approach. We have other countries, of course, where interruption has happened already, where we need to think about how we draw down resources fairly rapidly, and I'll come to that in a moment. And then we have the higher risk countries in the middle, which include countries that have got vaccine-derived outbreaks, as well as a risk of the spread regionally of wild polio virus moving into those countries as well, which include countries like Syria and Kenya and others, particularly in the Lake Chad basin. So we need to have a really good plan to make transition work. We need to be very clear on which countries and which category and what the risk assessment are in each of those countries and how we're going to align our financing behind that. That's one of the reasons why, of course, getting that planning into the general programme of works at WHO is so important, as it is represented, and getting a really strong investment case behind each of those components. Going back to the question, what's the responsibility of a donor like DFID and other donors? Making sure we've got really excellent investment cases that tell us where we can direct our resources and how we can have the best impact. So that's a really important part. The polio transition planning Dr. Guerra and his team are leading is going to be critically important, and we work closely through the sort of governance mechanisms and other ways to comment on that and get that in the right place. Now, of course, those countries where we've seen interruption, the issue is we've got a lot of people who are paid for from polio. We've got a lot of capacity that's paid for by the GPEI. And what we, of course, need to see is that the national plans in each of those countries is very clear on the roles of the people and the capacity and the resources available in those countries, and that they're being planned into country-level systems. And this is where, of course, the links become very important to broader transition issues. So we're seeing countries that will be transitioning from Gavi support. In time, we'll have the Global Fund transition happening in countries that are being affected as well. Sometime hence, but it will be coming, and we need to plan for it. We've, of course, got changes as countries become middle income, around access to grants and concessional financing. So this is something we need to see in the round. But the opportunity we have, of course, is that this is laying the foundations towards UHC. This is all of us seeing an opportunity to align our support as donors, as partners, as multilateral partners, but mainly actually as governments in the countries concerned, to take a robust position on national plans, not just for polio transition, although we need to have that as an explicit part, but for health systems, for health financing. We need to see higher levels, of course, of tax, higher levels of allocation to health, and actually better spend on health. Some of the great opportunities we have, therefore, to make transition work include the new and more substantive engagement we're seeing from the World Bank under Jim Kim's leadership around the Human Capital Project, around institutions like the Global Financing Facility, around the excellent work that we're seeing from Gavi and the Global Fund in engaging with governments to actually really push these issues of broader health systems and broader health financing. And I should say, just to be clear, that in saying that, I'm mentioning Global Fund and Gavi, that's not looking to Global Fund and Gavi, of course, to be generally funders of health systems. They have very focused jobs to do, and we need to keep that specialisation and enhance their impact, and they are very effective institutions. But we can use their profile, their leverage, their influence alongside other institutions to help build the case for strong health systems and health financing. And I think as donors, again, on the financing, and I'm sure I'm coming at least to the end of my time, so I should be coming to a close, but we need to think very carefully about how we align our financing behind national plans that are very clear on the risk assessments around the loss of capacity, but also on the opportunities. We need to think about the modalities, the multilateral development banks, and the use of concessional and other sources of financing, including loans, behind good health systems. And we need to make sure that we're putting countries in the driving seat so that we're all aligning behind those systems to make those work. So there really are risks. There's going to be a big change in financing. At the moment, global assistance for health is about $35 billion a year coming from donor countries. It's been about $35 billion a year for the last 5 or 6 years. If you look at the donor landscape, it's probably not going to change a great deal. Speaking as the UK We've hit 0.7% of our gross national income as official development assistance. We're the second, the third largest financer on global health, generally in many of the areas that we're looking at. We're committed to seeing the job through, but of course we have many calls on our resources, so we're unlikely to radically change our allocations to health. And if you look across other donors, it's a very similar situation. So we hope to see a continued 35 billion or so a year for some time to come, being deployed really effectively, but it's going to have other sources of financing, and domestic financing is obviously the main way that we achieve what we want, which is ownership, focus, country-led approaches, and sustainable impacts that are going to achieve our outcomes. So thank you very much. Sorry for using all my time, but I'm happy to take questions when the time comes. Thank you.
Yeah, thank you, Danny. Danny, I just want to follow up a question here. Yeah, just hold on for a minute. Because I think not only that, I mean, I think it's really nice that you focus on the country level, and you also mentioned actually the impact on a global level, because of course this polio transition has huge impact for WHO itself and at the global level as well, so we have to link those both levels. But you also mentioned the investment case. We have quite heard a lot about investment cases through, the need for investment case throughout the week. So I kind of want to dig on that a little bit, I mean, you are in the UK context, you also need to make your investment case. There are competing funding. You also mentioned, of course, domestic financing will be important, but is that then the way how you withdraw actually, or how you make your investment case? And there is a political choice to make, ultimately, by also the UK government in your case. So how do you convince them? And how do you manage that also with the other donors? Because there's Global Fund, there's Gavi, the GFF. Mm-hmm. How do you handle that?
So I mentioned that we've hit 0.7%, and I'll say it again because I'm very proud of that. Because, of course, the last 8 years or so have seen austerity in many countries around the world, including the UK, and we've kept at our target. So I think that's a great thing, and it's a confirmation of our commitment on international development. And we are one of the largest supporters on polio. We will see through the job on polio. We will be committed to the end. And we will help our great partners in Rotary, and the Gates Foundation, and UNICEF, and the CDC, and the World Health Organization achieve their outcomes. And we will work very closely, as we've been doing, with Dr. Tedros and with Ranieri and others on the general program of works and the investment case, I'm coming to it, on how we therefore make sure that all these investments across a whole range of areas are used really effectively. But you're absolutely right. We need to have very good analysis on how we use our money. We have a Secretary of State in the UK, in DFID, who's relatively new, and one of her main messages to all of us is it's not good enough just to show that it's a good use of money. She wants to know it's the best use of our money. And that sets up challenges, as anyone around the room will think, well, how do you show something is absolutely the best use of your money? But it does mean that we're stretched the whole time to really go further and showing when we invest in Gavi and we think about the next stage of Gavi, Gavi 5.0 is coming up. We'll be having discussions at the end of the year to look at all of this. There are questions there about immunisation in middle-income countries, where we've achieved great equity outcomes in low-income countries in terms of core rates of immunisation since the introduction of Gavi, which sometimes are actually very similar to wealthier countries, which is fantastic to see. But we have this sort of big dip in middle-income countries where we have a challenge. How do we operate through Gavi? Do we need to have new and innovative ways of operating to actually support immunisation in middle-income countries? The Global Fund replenishment is coming up. Those are ones that are actually within my department. Of course, the UK is investing across a whole range of other institutions. So I think the point is absolutely, we need to get a lot smarter. The resources we have sometimes feel like they're a significant amount of money. From the UK, we feel like it's significant. Globally, in terms of aid, it feels like it's significant, but it's not, of course, actually. It's quite rare resources. And compared to the level of challenge, despite enormous progress, if we look to the SDGs, we know we need to use our resources far better than we've done in the past. So we just need to get a lot better at demonstrating why we should invest in certain areas. The WHO investment case is going to be really, really important. It needs to show why WHO, which is an institution that historically people have often questioned whether it has as much impact as it should have. It's certainly got core functions and the normative functions. It's got other areas like GPEI, where it's done a fantastic job. But we know, looking back at the Ebola outbreak in West Africa, significant questions about impact there. And more generally, is it as efficient as it needs to be? I think demonstrating that WHO can really do the calculations, can show the impact and the additionality of why you put money through WHO to help on coordination and systems will be really important to build confidence and to actually start to secure more of the resources in ways that are working across the systems and building the systems. So we look forward to continuing to work with Dr. Tedros and others on that investment case and on taking the GPW forwards. Thank you.
Thanks, Danny.
Shall I go
So,
back down?
yes, thank you so much. we'll call upon you later again. So let me then come to our next speaker, and that's Matt McGregor from the Global Fund. Matt is actually the lead on the sustainability transition and co-financing policy in the Global Fund. And of course, we have heard already from Danny a little bit, that you need to have the best use. You have to prove the best use of money somehow, and you make your case. And of course, the Global Fund also has to do that, has to show the best use of money. The replenishment is coming up as well. So, Matt, if I may ask you to come and speak to us a little bit also on how do you want them to secure sustainable transition, and that's what you're doing in your team. So tell us a little bit about that. Thank you.
Sounds good. So thank you as well to the organizers for putting on this important event. The transition, as Danny said, is an incredibly important theme. And it's an incredibly important theme at the Global Fund, as well as for anyone who cares about eliminating the epidemics of HIV, TB, and malaria. So thank you for putting on this event. I'm happy to be here. I wanted to start briefly just by talking a little bit about the SDC policy, or the Sustainability Transition and Co-Financing Policy, because that's the policy that governs the Global Fund's work to try and manage successful transitions and support countries to sustain the gains they've made, as well as to scale long term. And really what the policy does is just brings together three interrelated themes. Transition, which is nothing more than really just a process whereby gradually the Global Fund will move away from financing countries. Sustainability, which is really the desired outcome of our investments. How are we increasingly ensuring that we're investing our money in a manner in which allows countries to continue to scale even beyond Global Fund financing? And co-financing, which is one of the tools, but just one of them, that we have to get there. And it pulls together these three themes with the overall goal of our investing our money more efficiently to help us end the epidemics and support countries as they move toward UHC. I think it's really important to note that the Global Fund grew out of both a recognition of the changes in the global health financing landscape, or the STC policy grew out of a recognition of the changes in the global health financing landscape, but it also grew out of some real tough lessons learned, where we saw early transitions, where particularly in Eastern Europe, we saw some service coverage interruption, we saw challenges in sustaining some of the gains we had made in data quality, in governance, and so it was a reflection on that and really a doubling down of saying we need to increasingly ensure that we're a good partner in managing and supporting this process with countries. It's really based on a number of core principles, and I'll go quickly through this. The first is that it's very clear that we need to embed sustainability throughout the development continuum. Most people think about transition as those few countries that are exiting Global Fund financing right now, but it's not. It's really about a long-term process of working across the development continuum to strengthen the sustainability of investments. The second core principle is the need to increase domestic financing. As Danny mentioned, and I'm sure pretty much every speaker will mention, we need to find ways to both increase overall financing of the diseases, as well as co-financing of specific interventions that have increasingly been reliant on external financing. Third, there's a principle that we need to accelerate planning for transition, particularly in all upper middle income countries and lower middle income countries with lower moderate disease burden. This is based on a fundamental lesson learned, which is this takes time. It's not easy. It's not something that you can do in 3 or 6 years. So we've got to start accelerating our planning early. Fourth, a recognition that this has to be flexible and based on country context. All countries are different. They have different financial, epidemiological contexts, and we can't think that one particular solution will be perfect for all of them. And then the fifth is really the fact that this is not a global fund issue. The fund is a partnership organization, and we are going to need to work closely and rely on and coordinate closely with our partners to manage these transitions. There's a ton in the policy. I'll spend the rest of my time talking mostly about transition, but I sometimes think it's helpful, particularly for those of you who are not that familiar with it, to think about it as as what it's asking countries across the development continuum. Essentially, if you think of low-income countries to upper-middle-income countries, the policy asks slightly different things of each country depending on where they sit. On the left side, it's really where we're thinking about how do we increase long-term sustainability. If we don't have systems aligned, how do we start the early and tough conversations about aligning systems? How do we gradually pick up program costs? But then as you move over here, which is where I'll spend the rest of my time talking, this is really where we see the need to strengthen transition preparedness. It's not because every single country is exiting global fund support in this side, but it's because of that recognition that we need to plan early. And this is where we need to see accelerated co-financing of interventions, a strong emphasis in our grant design on planning, on making sure that we've analyzed the right bottlenecks to successful transition, and we're actively funding them to try and fix them. And then finally, the policy pulled in the concept of transition funding, whereby countries who become ineligible for global fund financing will be able to receive one round of transition funding to hopefully smooth this transition to full management and financing of the national disease response. So I want to talk a little bit now about perhaps to go back to Danny's point, and that's where my slides end, the fact that there's been enormous progress. So first of all, the Global Fund's emphasis on sustainability did not start with the passing of the STC policy. This has been something that the Global Fund has been thinking about for a long time. And if you actually step back and you look at regions, particularly those that are closest to transition, countries now manage the vast majority of the national disease response, and they've made significant progress. They've picked up the vast majority of human resources, the vast majority of service coverage, the vast majority of health products. So we've made significant progress in working closely with countries to get them not only to scale, but also to pick these things up. We've also seen, since the approval of the policy, a significant embedding of the thinking around transition in every part of the Global Fund's model, in the way that the TRP reviews our grants, the technical review panel, in the way that our grant approvals committee reviews our grants, in the ongoing work of country teams. So we've taken some pretty significant steps forward. That said, we should recognize that this is going to be challenging. And not only will it be challenging, we are seeing real challenges. And I can't go through all of them, but I wanted to highlight a few, particularly around key and vulnerable populations, civil society, some of the transition bottlenecks related to systems. So first and foremost, around key and vulnerable populations. When we think about this challenge, we know that in early transitions, we've seen disruption in services for key and vulnerable populations. And when we think about this, we really have to note that this is about trying to foster country ownership of something that countries haven't particularly been interested in financing in the first place, which is in many ways why the Global Fund has taken a lead in making sure we finance services for key and vulnerable populations. While it makes complete epidemiological sense and it makes human rights sense, we often haven't seen the type of scale that we need in domestic financing of these services. And so there are going to be challenges in pushing countries to pick these things up when they've been externally financed. One thing we're doing to help mitigate that risk is making sure that our co-financing policy is now tailored. So if you're a UMIC country applying to the Global Fund, the additional commitments that you need to make in order to receive Global Fund financing now have to be specifically focused on addressing transition challenges or key and vulnerable populations. And what we're seeing as we see funding requests come in is more, probably different in terms of scale and scope, but more commitments to finance things that we know rely quite significantly on the Global Fund. Second challenge, I think, is around civil society financing. The Global Fund has taken a lead in making sure that we finance and build the capacity of civil society organizations who are, quite frankly, essential to helping us end the epidemics, particularly in HIV, but also in TB and malaria. But we know in this process we've created some dependencies. There is a significant amount of financing of civil society organizations on the Global Fund. So one of the mitigation factors or mitigation strategies is we're working closely with civil society as well as with country governments to see to what extent we can publicly finance the services provided by civil society, often referred to as social contracting. But we should recognize that this is going to be tough. And we should also recognize that at the end of the day, financing civil society is probably not going to look exactly the same as it does under the Global Fund. because governments don't necessarily finance the same way that we do. It's not to say that we shouldn't be pushing for it. We absolutely should, because they're critical. And then I think the third challenge, and I'll move toward the end here, because I would probably imagine, although I will note that my notes were longer than everyone else in our little planning document there. Two other things. One challenge we're going to have is early transition planning. It's not easy to start thinking about this, because what it means is we fundamentally think about not getting external financing. So one real important question we have is, how do we foster early planning? Not just in countries that are exiting now, but countries that are 3 or 4 or 5 allocation cycles away. We're doing a lot of this. We're increasingly trying to get countries to finance analysis of their transition readiness, as well as develop plans. To use a statistic, about half of the disease components on our projections list have done a transition readiness assessment. They're in the process of developing work plans. And so we're trying to foster that early planning. And then finally, the last challenge I'll highlight is what I'll refer to as kind of systems-related bottlenecks. These are things like M&E systems, procurement systems. And they're fundamentally related to how we move from externally financed programs to embedding those programs within the health system. I think the question that is challenging, and I think procurement is a good example here. We've seen a number of challenging examples of countries being able to access quality, affordable health products once they've taken over domestic procurement. The challenge here is that a lot of these questions are really complicated national ownership questions. They relate to things like making sure that the capacity of a regulatory agency is sufficient. They relate to things like making sure all drugs are registered at the national level, that oftentimes go beyond a little bit the core work of the fund. And so they're going to be really challenging systems-related issues that we're going to have to push as we move forward. So my last 2 points will just be, because of this, we have to recognize that this will be a partnership effort. I mentioned this at the beginning, but it's really crucial. The Global Fund is really trying to, under the policy, strengthen the amount of collaboration we do with our partners around transition planning, around domestic financing, around searching for new sources of potential financing to finance some of the key things we know have gaps. And we're going to have to recognize that for the fund specifically, this is challenging, because most of the places that we're transitioning are places that are very few other donors still exist. This is particularly going to be important to our work with the WHO because of the WHO role in all of these contexts. So I'll close just by saying, while there are real challenges right now, we're at the beginning of this process. The STC policy is a really proactive and I would say progressive step forward, and a step in the right direction. But we're going to have to recognize that we're at the beginning. This will become a topic that isn't just for UMICs and LMICs with lower moderate disease burden, that at every portfolio that is financed by the Global Fund continuously has to grapple with. And I think the key challenge for us as an institution is, how do we increasingly become a good partner to support countries in planning and preparing for transitions so that they can sustain the gains and scale even after Global Fund financing. So I'll stop there.
Thanks, Matt. Matt, can I just ask you one more question? And I'm
I
glad
thought that if I went long, I wouldn't.
I know. Short answer then. No, but I quite liked your model actually around, really being clear about the outcome is sustainability, the tool is co-financing, and the process is really the transition. And you also, I'm also glad that you actually mentioned the challenges, because I would have asked you, because the policy is a policy. It's not yet, the implementation of it. But I also want to bring you back actually on something else. You mentioned that some of those challenges really at the very concrete country level. So let me come back to your governance structure. Let me come back to your headquarters level. You have there are lots of interests involved here. You have a multi-stakeholder governance structure as well as Global Fund. Different stakes in here. So how do you handle that actually vis-a-vis this transition process? Is that also a challenge?
That sounds like a question for our first speaker.
Short answer. I know, difficult. Sorry.
The Global Fund is a unique institution. We have a unique and, in my mind, fascinating governance structure. We also have lots of different opinions. I don't think I'll talk so much about the governance structure, although maybe Danny can if he wants. But what I would say is there's a lot of debate about the exact path to get countries to transition successfully. And that extends to the board level, it extends to the secretariat, it extends to every CCM, country coordinating mechanism, every technical partner. So I think we have to find increasingly ways to get behind the recognition that there will be a lot of paths to getting there. Countries are going to get there differently. But let's be clear on what we're actually trying to do. And I actually think that the WHO and the health financing team and the work that they're doing has a really great way to talk about this, which is what we want is sustaining coverage, sustaining and scaling coverage. We don't necessarily want to sustain programs. We don't necessarily want to sustain interventions. We want to work closely with countries to sustain and scale programs. In some places, what that's going to mean is things like finding ways to finance civil society to provide harm reduction services. Because we don't have many great examples of government financing of harm reduction programs. In other places, it's going to be integration of donor-financed vertical systems into the health system. In other places, it's going to be massive increases in domestic financing, where countries are, quite frankly, just spending too little. So I don't know if this answers your question, but I think it speaks to the fact that there are a lot of different opinions, different interests in this. I think what the policy is trying to do, and the Global Fund's work on this is trying to do, is trying to say, fine, that's okay. But getting where we want to get, which is sustaining and scaling coverage with domestically managed and domestically financed health programs, is where we all want to go. So I'll leave it
Thanks
at
a lot. Thanks, Matt. Very useful, and of course it raises even more questions, but that is then for you to ask. So let me then come to our next speaker, and that's Brenda Weining. She is the chief of the Global Drug Facility of the Stop TB Partnership. And of course, Brenda is an expert on pharmaceutical policies and has worked actually on market approaches to access to medicines and diagnostics in resource-limited countries, so she is really specialized around that topic. And so we want to hear, Brenda, from you a little bit, what is the impact of transition on access to medicine, especially to TB drugs? What does it mean for you?
Good. So thanks very much for inviting me here today. This subject is really timely in the TB world. It's probably our #1 issue that we're dealing with today, so we're really happy to see such interest in coordination and efforts to look at this issue. Following on what Matt said, the issue we're really talking about is what happens when, in the TB space at least, procurement that had historically been managed in a centralized manner becomes more decentralized. What are the challenges that we face at the global level, and what are the challenges that we see at the country level, and how do we think about addressing them? So I have 3 slides. One is just to give you an overview of what the TB medicines market looks like and how it's evolved, and what the GDF's role, the Global Drug Facility's role, has been in creating and shaping that market. Then a little bit about what we're seeing now in terms of challenges as countries start procuring TB medicines, specifically first-line medicines. And then finally, the 3rd slide is on what are some strategies that we might think about in mitigating some of the challenges that we're seeing. So for those of you who don't know much about GDF, you might be surprised to know that it's been in existence since 2001, actually before the Global Fund. And it was established by a bunch of donors, DFID, Canada, USAID, specifically to bring quality-assured, affordable first-line medicines to countries because the markets didn't exist. It just wasn't possible to get them. And so they started very quickly with grants that were given from these donors through GDF, given to countries, along with technical assistance to help on procurement and supply chain management. And that was linked to the programmatic work that was being done on behalf of these donors in country. And that was the model, basically. So money was flowing for several years before procurement and the Global Fund started around, let's say, 2004, when real money started flowing for procurement of medicines in the Global Fund. So we started initially with first-line medicines. And then in 2006, we launched an online system that allows anybody who's in the public sector or a not-for-profit sector to buy medicines through GDF. So we do have many clients, other than the Global Fund, who buy through GDF through this online system. And then in 2007, we added second-line medicines and pediatrics, and a year later gone into diagnostics. So now, GDF is a one-stop shop for all TB products across the spectrum. So GDF has really been building the markets across medicines and diagnostics since the beginning of these markets coming to play. I'm going to give you some examples of the success we've had in second-line markets here. Just to say that prior to 2007, there really was no market for second-line TB medicines. So we're still looking at a fairly young market. If you think about the progress that we've made over the past 10 years, we went from 5 to 28 suppliers in the past 10 years, and from 8 to 86 quality assured products. That's pretty dramatic when you consider, sadly, the number of people we're putting on treatment is not increasing at that same rate year over year. So it's a very small market that we've still been able to incentivize suppliers to come in. We've also been able to make that market more efficient. We've seen dramatic decreases in prices even just over the past 5 years, more than 50%. We haven't announced our new tender prices, but these will go down substantially again in the next month. We've been able to reduce lead times from the beginning, the early days, it was 6 to 8 months. So countries would order 2 years worth of medicines at one time because of the lead times. Now we've been able to reduce it to less than 3 months. And we have several examples from some of my staff in the room who've been able to get these products to countries in a matter of a few weeks. We've had very few stockouts with our clients because we've had from the beginning more than just buying. It's more about just placing your order and resell. There's a link to quantification, checking in country, the TA and capacity building, and making sure that the amounts and the drugs that are ordered are correct. We've also seen a lot of innovation. Unfortunately, it's only been over the last, let's say, 5 years. So while we're still hoping to see innovation in the first-line space, we're still using drugs in first line from the 1930s, 50s, and 60s. That's when our drugs were developed. I challenge you to think of another disease that right now, the main treatment was developed in the 1930s. That's where we are with first line. Luckily for second line, we have seen recent developments. We've seen massive developments in the diagnostic space. So it's moving in the right direction. And why we've seen this so recently is because the fruits of all those investments that were made in TB are now coming forward because it takes time. Similarly, we've seen a lot of evidence coming out, and you can see just by looking at how active WHO is. They have been very busy. If you look at the period of 2005 to 2007, they only had 2 guidances that related to commodities. And if you look at the same period from 2015 to 2017, they had 11. So because there's so much research coming out, more products coming out, they're busy putting out more guidances, and things are finally moving in TB. We want to make sure that that keeps going as the world changes how it's financing and organizing. So I think in order to make sure that we keep the momentum, we need to understand how we got there and what was responsible for seeing these achievements. When we had the massive investment in the 3 diseases, most of the donors who are putting money into the procurement of these products, they converged around certain policies. Same quality assurance policies that relied on WHO pre-qual or stringent regulatory authorities. Requirements that you must use medicines recommended by WHO, concurrent with their recommendations on their standard treatment guidelines. We had some donors who were coming in and giving money for new introduction of new products. Canada, DFID, Unitaid, big model for Unitaid. They gave grants to introduce new products, and the Global Fund was there for scale up. And everybody knew that that was kind of the cycle, and that kept suppliers interested in innovating. That kept the research going, and we need to figure out, as this changes, how do we keep that cycle moving? From the GDF perspective, because we've been pretty much the main buyer, we're the biggest supplier to the public sector. The Global Fund has had a requirement that countries must go through the GDF if they get funding for second-line medicines. And we've done most of the procurement for the Global Fund for first line, and increasingly now for diagnostics. So what have we developed as tools along the way? Certainly pooled procurement. That started from the beginning, and it's still a critical tool that we use, linked to the technical assistance. The pooled procurement without the technical assistance is not effective. We do a lot of work on demand generation, trying to work with the WHO to know when they're going to make new guidelines, when they're going to recommend new products so that we can get countries ready to adopt as quickly as possible. Working on the supply chain to help countries figure out how to phase out old products, phase in new products. We developed a strategic rotating stockpile. This is a physical inventory of medicines that we own that sits with our procurement agent. This is what allowed us to reduce our lead times. It also allows us to respond to emergency orders. When you have a market that is this small, you cannot expect suppliers to hold on to a lot of inventory. They're just not going to do it. They will have too much waste. And if you ask them to do that, the end would just be a much higher price. So the strategic stockpile has been a really effective way to help get products to countries quicker than they would happen normally, and give some assurance to the supplier that there's going to be regular ordering from GDF. We also have a flexible procurement fund. This has been really critical for countries who choose to buy through GDF with their own money. If they don't have the ability to comply with 100% prepayment policy, this is money that we confront them to say, go ahead to our procurement agent, please place the order with the supplier. If they don't pay, we will cover from this fund. And that's been quite successful. It's small, and we need to find alternative means to help countries address this particular challenge. And then we've really been very involved in shaping other global policies that limit access or affect markets. So we've worked very closely with the pre-qualification program, for example. We came to an agreement last year that they would waive fees for 84% of our medicines because the volumes were so small that the fees would really be a disincentive for suppliers to continue making. Various policies that we've been able to influence, as well as market coordination. So we lead a group of all stakeholders in the market, and we come together and try to see if we can coordinate and work on common issues. So it's been quite successful. However, it's still a fragile market, right? And it still requires coordination. And so how do you do that when the procurement's not centralized, but you still need this coordinated group of actors to keep this whole machinery running? That is the challenge. And we are seeing a lot of challenges now as countries begin to take on domestic procurement. It's been, for the most part, mostly focused on first-line medicines and diagnostics is where we're seeing the most challenges. I should say that the challenges that we're seeing now are not new. I got into this field in the early 1990s. This is what people were talking about then. They were talking about it in the 70s, and now we're talking about it today. The reason that it's new in the donor community is because, as I said in the beginning of the presentation, there were all these policies that created a bit of an artificial environment, if you would, saying you have to buy these drugs of this quality, WHO recommended, all these checks and balances. When you take away those levers and you say now, use your own system, well, then we're back to where we were. And we're back to the way things are with all the other medicines that don't have a donor-funded financing. So these are not new challenges. But these, I would argue that because there still is a substantial amount of money left in the three diseases, that we use the amount of money that's left to help address some of these that will provide more sustainable systems, as Danny said, health systems going forward that will make them less reliant on donors and external organizations and serve them beyond the 3 diseases even. So what are some of the early observations that we're seeing as countries assume more domestic procurement? It varies considerably country to country. Some countries are doing just fine. You would not even know that there was a change in financing. They may be buying through us, they may be buying through somebody else, but it's a quality assured product, or prices are okay, they're doing okay. There are many others, however, who are facing challenges. And I should say that it's not contained to a certain type of country. We're seeing it across all income levels, low, lower middle, and upper middle. We're seeing it across all disease burdens, low and high. So what are we seeing? We're seeing failed tenders, high prices. We're seeing purchase of non-quality assured medicines and diagnostics, products not recommended by WHO. We're seeing long lead times, and we're seeing increases in stockouts. We've seen over 30 examples of increases of stockouts for first-line medicines without systematically looking, just because people are coming us for emergency orders. When you think about the root causes, Matt had mentioned some of them earlier in his presentation. Sometimes the volumes are too small to attract suppliers. We see long, protracted tender processes and limited capacity in countries. We're seeing procurement laws that don't really lend themselves well to health. The supply is very complicated. It's very difficult to procure all the medicines you need, 5 medicines from 5 different suppliers, different volumes, and have them all arrive on time from when you need them. We've got development banks stepping in for financing that have different quality policies that are not what the donors had. We have suboptimal planning, and we have global procurement policies from some of the leading agencies that are outdated and need updating. So how do we think about strategies to address these? We really need collaboration, as Matt said. This is bigger than all of us, and all of us are going to be needed to fix it. We need to agree on what are our market and access goals at the global and national level. We need to learn from and expand upon the tools that we know work and not revisit tools that we know didn't work from the past. Again, these are not new problems. We need to think not as financiers anymore, but go back to a development approach. If you want, as Danny said, if you want stronger health systems, better financing, that's a development approach. And that's how we need to think as we think about moving forward. We need to look outside of health. Lots of pressure from domestic purchase of locally produced products. We need to involve those sectors, finance, trade, etc., and get them involved in the conversation. Finally, I think we need to convene a group of stakeholders like yourselves that can help and that can address this. We need to look at this from the country level and come up with some type of a dashboard that says, here's the things that we need, we know you're going to run into as problems, and keep track of, are they ready to assume domestic procurement? And then we need to work from a global level and say, what are the key actors we need? What are their roles? What do we need each actor to do? And then implement, monitor, evaluate, and redirect as needed. And finally, we cannot delay. We need to act now. We've already seen what's happened with first-line medicines. Now, countries are beginning to procure second-line medicines. We don't have time, because if enough countries leave the quality-assured market, it will be very difficult to keep it intact for those who want to stay. Thanks very much.
Thank you, Brenda. So don't delay. So I don't want to delay too much here now as well. We are getting a bit delayed. So Brenda, just one question maybe to you, and maybe a quick answer from your end. But you mentioned that you need to work with other sectors, and I'm quite intrigued by that, because we hear that all the time. But we also hear that they speak different language, and they have a different meaning to the different terminology used. So how do you manage that, actually?
So I think, this is it's very good timing because we have, the first high-level meeting for TB in September. And there the target is the heads of state, right? So here's our perfect opportunity to be able to move beyond the health sector. Now, we need, as a global community, to decide on, for example, what is the quality of medicines that we're going to accept in the next iteration of however these markets are going to evolve. I don't believe that as countries assume domestic procurement, that they will need to stay in the pre-qual market. Nobody can say to South Africa, you're not doing a good job because you're not buying pre-qualified medicines. Their medicines are fine, and they don't want to buy pre-qualified medicines. And we need to help countries who are getting pressure to buy domestically produced medicines that are not of a good enough quality. We need to come up with a what's good enough if they're getting pressure to buy a domestically produced product and they're not able to go into the pre-qual market. What is that next level that we can accept as good enough? And that needs to be a conversation that involves a very high level discussion between trade and health. And I think the high-level meeting is the perfect place to do that. We need to call on the heads of state to say, we will not allow poor quality medicines to be used in our countries.
Thank you, Brenda. And thank you also for mentioning the high-level meeting, because, of course, it is an opportunity also for TB actually to bring in a political commitment. Thank you, Brenda. And with that, actually, as you mentioned also, that we need to move out of the silo, and the high-level meeting is such a possibility because it is in a political venue of the UN General Assembly. I do want to move here now to Susan Sparks from WHO. She is a health economist in the Department of Health Systems, Governance and Financing. And of course, if you talk about UHC, you also talk about moving out of the sector and bringing different sectors and different actors together. So WHO has that role to bring those actors together and help them to transition into UHC with a lot of domestic financing. So how do you do that, actually?
Okay. Minor question. So thank you for having me. It's good to be here. I think what's important here is to start with the caveat that I'm on the health financing team at WHO. And so I speak for myself and perhaps the health financing team in our approach to transition and how we're thinking about this issue and working with countries on this particular topic. So I was asked to speak on 3 specific questions. And so for the sake of time, I have my notes prepared by each question. So I'll try to go through each one systematically. So first, I was asked to talk about the responsibilities and expectations of countries in this process. And so I think what's important here, and I start with the country aspect of this because I think we come against this often, is oftentimes it's framed as donor transition, but it's actually a country process. It's a country transition process primarily, because if we think about what is transition, so transition means that countries, and primarily governments, are going to have to take on the financial and managerial and often technical roles that donors have been financing previously. And so this really places the country at the center of that dynamic. And if you think about, okay, well, what's triggering transition? And so obviously that varies from donor to donor, but oftentimes it is this economic growth question, right? So countries are transitioning both from a donor perspective, but they're actually also transitioning economically and demographically, epidemiologically. And so what this does is it takes the donor transition piece, and again, from a health financing side, and it places it within that broader health financing space. And so as countries, what we know, as countries get richer, donor financing tends to go down as a share of total health expenditure. But what then we want to happen as countries get richer is that public financing, so prepaid, pooled domestic resources, then come into that space. And they come in even at a higher rate than the economic growth. And so the question for the countries are grappling with is, how do you translate that economic growth into health sector resources? And so first, that's a tax revenue-based question. And then it's a prioritization within the overall budget question. And so by placing it within this context, what it does is, what we know from a UHC perspective is that this public financing, so increasing public financing, is critical to make progress towards UHC. And so then if we think about, okay, so what does that mean as part of this overall transition process? What do countries, what's the expectations or the hope that countries will do from a policy side? And this means diversifying and strengthening their public resource base and also using their resources more efficiently and effectively. And so this isn't a transition question, right? This is a question that all countries are grappling with. And so from our side, it's about thinking about transition as an opportunity, as a political opportunity. So great, countries are growing economically. There are some real challenges and real problems associated with this process, but how do we frame this overall? How can countries frame the multiple donor transitions? It's not just the Global Fund, it's not just global polio eradication, it's multiple transitions in the context of their broader health financing decisions, because ultimately it's a ministerial discussion, it's a Ministry of Finance discussion. And so this reframing, and this really does take leadership and stewardship in countries. And so I think that what we're finding, we spend a lot of time discussing this type of issue in these types of forums and in Geneva and other places, but actually where the rubber hits the roads is in the country. And if you have that, how do you foster, how can countries foster in themselves this strong stewardship role? So now moving to, I was also asked to speak about the responsibility and expectations of the international community. And so here it gets a little bit tricky. From our side, our concern is from a health financing side that oftentimes the conversations get really focused on gap analysis, on the revenue side. How do we have a one-for-one replacement? How do we get the co-financing targets lined up? And an example here, the 2018 Ghana health budget was presented, and 50% of the goods and services budget was for Gavi and Global Fund co-financing. This is a country that its national health insurance fund hadn't paid providers in over a year. You have when you start to take these different pieces and think about, okay, what is the Minister of Health actually managing in aggregate? It becomes quite clear that some of these tools that we use for global level advocacy, so targets, investment cases for specific diseases, actually might need to be differentiated between what's actually useful for countries. Is an $86 a day spending target feasible in Tanzania? Does that distract from the conversation? Does then the conversation all become about how do we meet that target instead of saying, well, we're not actually executing our whole budget right now. So how can we focus on that to spend what we have? What are the gaps? What are the problems there? And then I think also it's this opportunity for reflection and change. And I think, as Matt was saying, the Global Fund was, so using that example and picking on that, it was developed for a reason. I mean, PEPFAR, the same, emergency responses. Health systems weren't able to handle and meet the objectives. And so we're going to dump money in, 3-year grant cycles. And the sustainability question wasn't the immediate pressing issue. And so now we kind of transitioning from the MDGs to the SDGs, this has become quite apparent, particularly in the context of UHC. But I think this question of, I think global policies are really important, and this rhetoric and dialogue and agreeing on these principles. But what is the Global Fund doing in terms of changing the CCM makeup? How is it changing its grant modalities to help facilitate the fact that these do take longer term investments? And so how can you broaden out some of these investments to not just be on the 3-year short-term cycle? And I think these are discussions that are being had, and so which is a good thing. So now on the next question. So I was asked to talk about the challenges for transitioning countries in achieving UHC. So I'm going to change it a little bit and talk about some of the opportunities that we think UHC might bring to this agenda, recognizing, in full disclosure, all of the challenges that have been discussed. And so first of all, and Matt has preempted me, so which is great. I can be more efficient in my delivery. So what we're really trying to do is change the conversation and say, if universal health coverage, so it embeds these principles of financial protection, quality, effective access across a suite of services. And so this is really then saying, well, how do we sustain that coverage, recognizing that donors have been funding really necessary priority services? And so then this transition question becomes, how do we make sure those people still get those services? What do we need to do from a government side, from a country side, from a CSO side, from a donor side, to make sure that coverage is sustained? And in this way, it brings the efficiency angle really central. Because when you look in countries, and I think has been touched upon, this idea of you see 5 procurement systems, you see multiple supply chains, you see multiple uncoordinated IT systems. And so a lot of our work is starting to unpack this question and thinking about, okay, as this transition and sustainability question becomes central, how do we streamline some of those services, and what does that mean in the context of still maintaining the focus on effective coverage? And then the second is the UHC umbrella. I think that this is a very useful framing, is that it's not just about the specific program. It's about the overall health system. And I think also if you just think about it as a patient isn't just TB, a patient isn't just HIV, it's not just a pregnant woman. They're all of these things. And so the issue is, how do we look at that service delivery side and then think about how we align the financing and the supply chains and the procurement systems to match what those patients need? And so I think an example here that's helpful in the transition context is what Estonia did as part of its transition from the Global Fund. Is what they knew the Global Fund wasn't going to be there anymore. This is in the early 2000s or around 2007, 2008. And they said, okay, what are the services that the Global Fund is paying for? Recognizing that they had been kept parallel. And so they said, well, where should these services logically take place? And these were for, in Estonia, it's a concentrated epidemic, injecting drug users. And so they actually looked from a multi-sectoral perspective and said, okay, actually, maybe the Ministry of Justice should pick up some of these services, the TB services for prison patients. And how can that then be coordinated with the Public Health Institute? And they looked across that, the entire government really, and said, okay, these services need to take place, whether it's primary care or specialists, and then they said, how do we then align the domestic financing to meet that goal and to meet that objective? And it's not to say that there aren't continued challenges in that space, but I think it's a useful framing in terms of how to approach the issue of transition, rather than thinking of it from a top-down, replacing financing, but actually how do we make sure that those services are still available, and what makes sense from a health system and overall government and civil society and private sector space. And I think, as Matt was saying, that these are politically sensitive discussions. I come from a health systems, health financing background, and I've been working in this space about this question of integration, and it's such a loaded term, and working with health programs in different countries. But what I'm absolutely convinced about is if you don't get the different people at the table together speaking, I mean, I've done this work now in Ghana, Estonia, South Africa, and there's remarkable consensus. I mean, the programs, and others can speak a lot better about this than me, they're concerned with their services being in place. I mean, that's their primary objective. And so it's not an either-or question. And so how do you get the planning and the programs and the finance together to think in a more holistic way, and not just donor by donor or program by program? So then the last question is WHO's role in supporting countries and communities during transition. Again, coming from a health financing side, and also not speaking for all of WHO Geneva or regions or countries, but in general, what we like to think of is WHO as an institution doesn't actually transition out of countries, that we still maintain a country presence. And so I think one of the issues that we're trying to manage and to think about is that WHO can feasibly play a bit of a neutral brokering role in this discussion of how do you bring the various donors together along with the government to have these discussions. And so I think one even starting point is even DFID has been able to do this in Ghana by doing not just having a one transition assessment for a particular donor, but having an overall health financing assessment that looks at the multiple donor transitions that are ongoing. I mean, that's one kind of concrete step, so then those conversations can happen across. And then at the global level, and Maria manages the UHC 2030 working group on transition, but I think a lot of the effort and a lot of people in this room who are part of that group is how do we, and I think Matt also demonstrated this, is that we actually are coming to a lot of consensus on some of the core principles and some of the approaches. And so I think now the challenge for us here is how can that actually move down into countries in a feasible way. So thank you.
Thank you, Susan. Susan, I find it actually quite nice because you mentioned multiple transitions and we haven't talked about simultaneous transition yet. Yeah, I'm not sure whether we come to that, but I think we should flag that it's an important issue. You mentioned also ministries of finance because they are really important actors in here as well and to engage with them. You started actually at the country level, so you did start at the country level. I would say to some extent you ended with the patient, I mean the country at the center, and I felt like you ended a little bit with the patient at the center. Because you did mention, the people at the center, it's about the service delivery looking first at that and then see what you need coming from that and what flows from there. So if I take that focus around the patient center, and of course I know WHO has a mandate to engage with member states, with governments, and to support the ministries of health and with them also then the interaction with other ministries. But how do you engage also with civil society? Do you?
Yeah, so I think that there's an increasing effort. So I was just talking with my colleague from the HIV group that they've convened a group on CSOs and UHC, which I'm sure many people here were in that space. And I think increasingly it's clear this citizen voice and citizen accountability piece from a demand side is really important. I think on the Ministry of Finance side, I mean, I had the Minister of Health of a country said to me, listen, Global Fund and Gavi are talking about transition issues, but the Minister of Finance basically, he said, if I don't go to the Minister of Finance and tell them they're leaving on this day is tomorrow, and if not, then XYZ is going to happen, then the Minister of Finance isn't really interested in putting money into these, particularly the Global Health Initiative funded interventions. And so there's a clear role for civil society to generate that demand because these are elected officials. And so I think the UHC 2030 and increasingly as part of the UHC movement, this is becoming central. So
thanks, Susan. And actually that links me right back into our last speaker, and that's Rico Gustav, the Senior Sustainability Advisor from the International Civil Society Support. And Rico, of course, has been an activist, an HIV-positive activist for nearly 20 years now on AIDS, on drug use, on the rights of the marginalized population. So let's hear, Rico, from you, what does it mean? You have heard all of them. They're speaking about key populations, they speak about affected population, but what does it really mean from your perspective as coming from the civil society and from an affected population? What does transition mean for you?
All right, thank you. And thank you also for the last speakers also, because there's a lot of mention of communities, key populations in transition context, and that's something that we feel it's important to come not from civil society and the communities, but also embedded already in the global health financing policies, et cetera, et cetera. So I'm going to start to talk from the broader context itself, because I think when we are talking about key populations, in particular key populations on HIV, it's really important to actually consider the broader context of where we are in the world at this point. And we know that development landscape is changing, and this is probably a sentence that you already hear over and over again. It's getting difficult to actually raise more funding for development. It's getting difficult to raise more money for health. But there's also one important changes that hasn't been highlighted, which is ideological changes. There's a lot of political ideology changes in the current world that we're living in. The current narrative for overseas development assistance, for ODAs, no one is really buying into that anymore. There's a lot of doubt in terms of, you know, do we really want to give money to countries outside of our countries while we have problem in our country? So that narrative within donor countries are very strong. But at the same time, there's also, the world is getting more and more conservative. It's getting more and more fundamental. It's getting more and more prejudice in a way. And that creates a lot of impact to key population itself. What's happening in the US, for example, in terms of the comments around drug users will influence the lives of the drug users in Indonesia or in Philippines, because the world is getting more interconnected, right? So this is just the broader context, the first broader context that I would like to put forward. But also that relates to the second context, which is civil society and key populations. The space for us to engage keeps on shrinking. But also at the same time, there's criminalizing laws everywhere for key populations as well, which becomes major barriers. If we want to engage drug users, if we want to engage sex workers and MSM, and we want them to sit on the table, how can that happen if they're criminalized? It's really, really difficult to do that, and it's actually putting people on, there's a safety issues around there. Let's talk also about the dangerous assumptions in relation to sustainability and transitions. And I think the first dangerous assumptions that we sort of moved on from this, not entirely, but we are learning. But the first dangerous assumptions that we always have about transition and sustainability is that when donor leaves, the government would automatically pick up the tabs. And this is happening quite a lot, and in reality is that that's not what's happening. What's happening is that other donors pick up the tabs, and this is where the Global Fund and the PEPFAR all found themselves in this situation, because the bilateral donors leave from a country, and they have to absorb the cost, because the government is just not going to fund these programs. And let me tell you from the experience of Indonesia, because I'm Indonesian and I just know the country better. Bilateral donors handled harm reduction from the 2003 to 2009, and then suddenly, just in these donor countries, they had election, and then they just decided to, okay, so let's stop funding harm reduction program. And believe it or not, the coverage of harm reduction in Indonesia, because of the sudden departure of that particular donor, from 90% coverage became 0% coverage in 2 months. And after that, in 9 months, the Global Fund picks up the tab. But that's also become dangerous, right? Because then the Global Fund will have less space in terms of accommodating other programs as well, and they will have to make bigger investments, which they're not in the place to do at that time. But also, there's a second thing. There's this assumption that, in the first point, I just want to emphasize the need for a clear and strong sustainability plan and transition plan, because it's obviously something that is necessary. But still, relates to the second point, even though that there are sustainability and transition plan, it is really difficult to count on the political stability within implementing countries. Again, government changes in the countries. And even when they commit to 1 year of resources after donor leaves, that doesn't mean that they will continue on the second year, on the third year, on the fourth year, or actually committing to end the epidemic in their countries. It's a very different political dynamics. It's a very different types of leaderships that is needed to actually get it to that point. So it is really difficult, especially if there's no mechanism on how the Global Fund or the PEPFAR or donors can actually engage with countries after the transitions, because that's what's necessary, right? Because you want to make sure that after the transition, everything goes smoothly, the investment keeps on increasing or keeps on being maintained by the countries so that they can actually end the epidemic within their own countries. But the third dangerous assumption is that, because there's quite a lot of discussion today and also, for the last 3 years, 4 years, that UHC will solve everything. UHC is the answer of transition and sustainability. We have to understand that for key population in particular, this is just impossible if there are criminalization laws. How do you expect for health service to actually provide services for drug users, for sex workers, if those populations are being criminalized? So without strong community response, without strong community sectors within the UHC, and if we haven't been able to figure out how we can actually get communities inside this UHC conversation, it is impossible to actually integrate key population service into the broader health sector. So here are some of the identified and documented issues that we already noticed and we already observed. It's well documented. It's still happening. We're still trying to figure out what's the best way to actually deal with this. And as I mentioned, there are some, in some countries, the key population programs and the civil society programs were immediately defunded. It's just not in the government priority, and it's just not something that they will pick up. Even though that there are certain advocacy, behind the scene advocacy to make sure that government actually picks up the tab, it's just not happening. So this is just a reality of transition and sustainabilities. But the second one is also the most concerning, because civil society advocacy is something that is just not, everyone is confused on how we can actually finance civil society advocacy. Because obviously, even if the government is a committed government that would like to support key population services, but to fund civil society advocacy is a different thing. Because why does government wants to fund something to keep themselves accountable? It just doesn't make sense. They can hire a consultant, they can review their own policies and identify the gaps, but they won't be able to fund civil society advocacy to advocate for themselves. So the needs for international financing or foreign financing to support civil society advocacy is very, very clear, and it needs to be discussed. The governance of the response becomes government-centric instead of multi-stakeholders. In many cases, the government actually picks up the tab. But unfortunately, they pick up the tab and they feel, okay, this is my program. It got nothing to do with the communities or civil society. So even though that they provide grants to civil society, but civil society doesn't have any space in the governance of the response itself. So patient feedback there is missing. There's no feedback from the communities in terms of this service is not working. How do we improve the service? It's just gone. And the last one that I would like to highlight is procurement became a major issue, and Brenda already mentioned this a little bit as well. But most of the transitioning countries face double issues when donors leave. First, they're losing a huge part of the money to procure commodities, but also for EUMIC countries, then the moment they enter upper middle income country status, they lose privilege for discounts from pharmaceutical companies because of their GNI has increased. And this becomes really problematic, especially when they don't have the volume to procure the drugs themselves, because they've been benefiting from donors' pooled procurement mechanism. So this becomes a major issue, and the problem goes even further because, again, the civil society is not being supported for advocacy. So there's no watchdog in terms of stockouts, for example. So when stockouts happen, it can happen for a long, long time because there's no alert system at the country level. So in terms of the policy gaps, one thing that I would just highlight is that, and Matt mentioned this, it is true that we have been talking about sustainability for quite some time. I remember the Global Fund first actually speak about sustainability around 2007, but we don't really actually act on it. We don't really try to define what do we mean by sustainability until 2011, 2012. That's when we are actually questioning what do we mean by sustainability, what do we mean by transition, and then we come up with we try to come up with a definition. But this is quite important because the conversation around sustainability and transition is primarily driven, it's triggered actually by the resource constraints that we're having. Because the money is less, then we're starting to talk about transition and sustainability. There's nothing that we can do at this point. It's just a political reality. But one thing that we need to note is that transition and sustainability is not only about financing. It's about a lot of things. Again, it's a lot about governance. It's about programmatic sustainability. It's about cultural and leadership sustainability. And we need to tackle all these issues at the same time. Making sure financing is there is something that is excellent, but if there are no other, if that's the only sustainability aspect that we're focusing on, well, that sustainability is not going to be sustainable. Let me just put it that way. I can't remember where I was actually. Oh, sustainability. Yeah, thank you. So sustainability is defined only by coverage. I'll just brush this through very quickly because I have limited time. But making sure coverage is there is, of course, that's something that we want. But this conversation between quantity and quality is just not making any sense, because even you need quality to actually achieve the coverage that you need. You need to focus on what kind of programs you actually need to actually make sure that coverage is achieved. And the last one in terms of the policy gaps is that a lot of the existing policies in Global Fund and PEPFAR and Gavi, it address countries. It address, when they translate that into eligibility policy, it addresses countries and not necessarily key populations. And one of the major problems is because of the use of the GNI as an exclusion indicators. So the minute countries reach certain GNI status, it becomes excluded, or it needs to be excluded from the eligibility policy. And this is a problem because we do commit in our strategy framework, for example, from Global Fund, we do commit to actually respond to key population epidemics, but we haven't really figured out what's the best way to translate that into policy yet. So, way forward, this is my last slide, I promise. This is just the title of the presentation. But I think one thing that we need to recognize is that we are still learning. We are still trying to get it right, particularly for HIV transition and key populations and civil society. We made and we will continue to make costly errors. And this costly errors is, it's not money, it's lives. It's quality of people's lives, basically. So the question is whether this is the right time to actually talk about safety net, because we will continue to make these mistakes. But what can we do to actually make sure that people, key populations are not slipping through the cracks? And it's important to have this conversation. And second one is that readiness and risk assessment, it's being done, I think it's more, it's become a new normal in global health financing institution to actually conduct risk assessment. But each of the risks that has been identified needs to come up with we need to come up with mitigation strategies, even though that sometimes those risks are really difficult to address, but we need to start discussing that. And those really difficult risks to address is, for example, political willingness, because political willingness is just difficult to address, it's difficult to monitor, but we need to try to come up with a proper strategy to recognize that. Again, comprehensive procurement strengthening strategy. We need to build a procurement strategy, the capacity of countries to actually chain supply and to procure, instead of building a parallel system now, and then when the donors are leaving, then they have to they have to only use their national procurement system. And the fourth one is actually, again, we are still learning, and the context of countries are different. Some countries, they do have political willingness, but they don't have the fiscal space, for example. The strategy to address that situation must be different than the strategy to address countries where political willingness there's nothing there in terms of political willingness. So there needs to be flexibilities. But also a frank and honest discussion about commitment and willingness, because we need to start talking about the lack of political willingness in countries to actually fund key populations. At the same time, we need to also talk about the donor's commitment in that kind of situation. It's not a zero-sum game. I mean, we can't really continue talking about we have limited resources. We need to figure out how we can actually move forward from that conversation. And the last one is just that, global health institution needs to start talking with each other, because if bilateral donors continue to have sudden transitions, then we're all in trouble. And whatever investments that we've been making for the last 20, 25 years will mean nothing, basically. So thank you, and sorry for overtime.
Yeah, no, thanks, Rico. So I just want to say, please bear with us. We started a little bit later, so we are just running a bit later here. So my apologies to that, and also for a bit longer presentation as envisaged originally. Rico, and I would ask actually everybody to come up. As Rico, I do want to ask, maybe you stay there and the others by the time come up. I do want to have a round for you as well if there are any questions. But Rico, just to ask you one question, I'm glad that you mentioned leadership, you mentioned governance, but you also mentioned really the changing political context and really the drawbacks we see here in terms of the narrowness of the context and the conservatism which is coming up actually. But what does it bear as a risk for you as a civil society? I mean, would you continue to exist? So is actually sustainability something you want? Ultimately, because if Global Fund is sustainable, well, they may not exist anymore at some point. I mean, I'm a bit provocative here, but, what does it mean for you?
Yeah, no, I think it's an interesting question. And I think, in terms of the civil society sustainability, I mean, one thing that is obvious that is needed in this whole context, I mean, despite whether it's needed or not, is that advocacy is needed. Someone to keep government accountable is needed. So whether it's, from our long history experience for the last 100 years probably, civil society is best placed to actually do that. But if there's any other mechanism to actually do that, it will complement the work that we're doing right now. So for example, from with the United Nations presence. But unfortunately, in these cases, a lot of the multilateral agencies has also depart from a lot of these UMIC countries, so which makes it really difficult and leave only limited options. Thanks.
Thanks. So let me just open up now to you. So I just take one round of questions. Who wants to go first? One here, second there, a third question, if any. One here, okay. So we'll go. And one here, okay, that's it. So, please.
Great, thank you very much. Thank you for a fantastic panel. My name is Meg Davis. I'm an instructor at SARA, and I work as a consultant for some of the civil society constituencies on the board. And I think these were fantastic presentations and rich, and really appreciate the frankness. But I also think that as an academic institution, we have to take a step back and interrogate some of the underlying logics in this situation. We're talking about a landscape changing as if this was a natural phenomenon, this donor transition, but it's really not. This is a matter of political will. This is donors making a decision to withdraw funding. And I think, rather than just assuming that these things are natural, that the development continuum is some naturally existing phenomenon in which countries naturally move up and progress and then graduate from upper middle income to high income, the reality is that we're in a very complex and contested landscape. And regardless of what that landscape looks like, wealthy countries still have an obligation under international human rights law, under the International Covenant of Economic, Social, and Cultural Rights, under the Maastricht Principles, to continue to give what they can to support countries to fulfill the right to health. So I think the UK's commitment to stay with polio until the end of the epidemic is a laudable commitment, and I would call on the UK and other donors to make a similar commitment to HIV and TB and not withdraw based on one arbitrary indicator, GNI per capita, but based on when the ends of the epidemics are reached. Thanks.
Okay, thanks. So I'll kind of collect them and I'll leave you then to answer and pick to answer what you want, all right? So in the back, please short, introduce yourself, short, just a question, and then we go.
Yeah, perfect. Thank you very much. My name is Laura Kerr. I work for Results UK in the policy advocacy team. I think the presentations were great, but show that there are so many different elements when it comes to transition. At what kind of global fora and at the national kind of level, how do we make sure that these conversations around different types of transition, different issues, especially when it comes to vulnerable marginalised groups, where does that kind of coordination and alignment? There's a hint there that the WHO has a role to play. but how do we make sure that these conversations are happening now? Because transition is happening now. And if we don't get it right and learn the lessons, it is going to be those people who can't access or who have been accessing essential health services who are going to be further left behind.
Okay, thanks, Lara. Here is, here in the front, and then I'll come back to that.
Thank you very much.
Short.
My name is Santiago Cornejo. I'm the Director for Sustainability at Gavi. Perhaps a question to maybe Matt could elaborate a little bit on these multiple transitions, because something that we discuss a lot, but when we go at country level and we go into the details, there's not that many happening. So what do we mean by multiple transitions? And just one small comment based on Gavi's experience. I would like to emphasize the point of the last speaker, because I think in terms we have worked quite, I think, a lot on financial transitions. Looking at transition from the financing point of view, DRM, the changing behaviors even in country, understanding how we work together. So I think that one we are in a good path. But perhaps what we're not really looking is, because we're not just about financing, it's the technical side, the technical transitions. And we are seeing, at least in Gavi, is these institutional developments and gaps that we are seeing. It is one of the greatest challenges. So what can we do? And that lies a little bit to what Danny was raising about this health systems, institutional development. It takes much longer than economic growth. What can we do, and how can we work better and collaborate better on those cross-cutting issues, human resources, public financial management, and technical assistance approach? I think we have, in technical assistance, we haven't done a good job in really building the capacities. Thanks.
Thank you. And then the last question here.
Hi, I'm Kirsten Ockerfeld with MSF. So my question is for Matt. You mentioned the progressive uptake of commodities and other services, and as even also low-income countries are starting to do this now. My question is, how is the Global Fund able to monitor and track what are the drugs and how is this uptake going in countries, and whether the finances are available, and also how do you see the collaboration with other actors such as WHO and others to actually monitor that these are happening?
Thank you. So, who dares to start? Any volunteers? Danny.
Give it a go. Is that? Yeah. So, really interesting questions, and also my thanks to our fellow panelists, I think, for what indeed was a rich discussion, really helpful. I think there's a set of really interesting points that were raised, which relate to a number of things, including actually what Susan said about, we talk about donor transitions, and actually it's country transitions, which I think is a really important way of thinking about this, actually, when we talk about the changes we're looking at. Because it's correct, this is not, should not be driven by whether it's framed as ideological or political or other sort of changing attitudes towards aid. This has to be based actually on what works in the end. And I think a lot of, well, primarily the countries concerned, low-income, low-middle-income countries, and others that have transitioned themselves into a higher income bracket, have invested a great deal of their own money and their own time, actually, in their economic growth and their social development and other areas. And donors have been very invested in that too for a long time. And so we must make sure that what we're doing is building on the successes that we've seen and seeing through the challenges in exactly the way that you see. And I'm happy to say that we're very committed to the SDGs. We're committed to hitting the 2030 targets. We're the second largest funder for the Global Fund. We're the largest funder for Gavi. We're not particularly seeing, whether we say 1 or 2 or not, I don't know, but we're not particularly seeing kind of changes as such in terms of our long-term commitment and investment. We want to see through these processes. So, that desire for that long-term commitment is absolutely correct, and I think we're in it for the long term. I think donors are generally in it for the long term. There are certain political things that are out with our control. I mean, attitudes change in ways that aren't necessarily about individual MPs or governments. They're to do with the population in which you are based. And in the UK, there are a lot of quite, as you all know, quite kind of harsh attitudes towards the way that we invest money overseas. And one of the most important things, back to the question about investment cases, we have to continuously make the case for aid. And that's why Results UK and civil society in the UK is so important as well, because we need to continuously make the case and demonstrate that this is, in a way that sometimes feels uncomfortable to those of us who are committed to international development, but make the case that this is also in our interest, that a prosperous, stable, peaceful world is in everybody's interest. And we need to be able to make that case and show that case. So I think we're in it for the long term. I think think there are some things beyond our control that will change things. I think we need to make the case continuously. But I think also we'd all recognise that things do change. Yeah, I mean, most countries that we operate in would be pretty clear. They don't look to the UK or the Global Fund or Gavi for their long-term financing of their health or their human development, you know, because actually we do things like we require certain drugs to be used, or we have other conditions, or, you know, countries want to have their own self-determination. That is the objective of any country. And I see the way we bridle in the UK when the UN critiques us about certain kind of things when it comes and looks at what we're doing. So I think it is important that we recognise also that we need to build on what has and what hasn't worked. And I think the civil society point that Rico was making, you know, is a really important one. And we spent a long time as donors investing in civil society capacity and building advocacy capacity. And of course, one of the best things that could possibly happen is that civil society groups and advocacy groups are supported by wealthier individuals within the countries concerned, because you have that evolution, that desire for a plurality of view, and democracy grows and you have a desire to sort of drive forward social change that isn't being funded from outside, but is being funded from, you know, inside. That has to be where we end up on all these things, but it has to be evidence-based. It's not about just withdrawing. I don't think anyone wants to just withdraw and cause damage. We want to make sure, though, we're strict. And my last point actually is on the point about when ministers of finance listen to the point. I think that's a really important point. They don't. If you say, you know, we may well continue funding, you know, for the next 20 years, ministers of finance will say, well, I've only got this much money. If you say we are going to stop in 5 years' time, if the Gavi transition policy says by the time you hit $1,500 per capita, you're entering a process by which you have a very clear increase, 20%, 40%, 80%, 100% of paying for your vaccines, and then you have a kind of access to some pricing, and then eventually that's it, we're out. That's quite a long notification. And that means the Minister of Finance has to start planning in that manner. And that's what we're seeing. We've seen successful transition from Gavi support. Absolutely financial, but then you discuss programmatic quality. Is it the full range of vaccinations? I absolutely agree. There's a big, important discussion there. But actually, in terms of financing, which is a big, important bit of it, we've seen success. And it's partly because of being very clear that change has to happen and we're going to change the way the financing happens. So you have to draw on those lessons, but get it right in an evidence kind of way.
Thank you, Danny. Shall we hand over, Brenda? Anything from your end to pick on?
I guess.
Short.
Yeah.
Sorry.
Okay. No, it's good. No, I think just to say that I think everyone understands that you know, we're dealing with country transition, but I think, you know, back to your initial comment that these changes are not organic, we have to realize that, and we have to say it's the billions of dollars of investments that the donors made that created the artificial situation that we're now trying to figure out what's next. And it's fine to say countries need to bring money to the table, and it's fine to say countries have a responsibility. Everybody agrees with that. But I think what's missing is it's unreasonable to think this artificial market that we created is going to live past this donor investment. So what is next? And maybe it's not the same type of interventions and the same types of investments, but we need to figure out what needs to be done to make sure that people continue to have access to these quality assured affordable markets, even if it doesn't look like it does now. And to your point about WHO's role, to me, and getting back to the business case for WHO, this is a huge opportunity for WHO from, for example, the Essential Medicines Program, to get back to what was their core business before the 3 diseases came into play. And that was creating national guidance for policy and whatnot and helping countries to implement it. And a lot of that was diminished when the disease vertical money came through. And we need to go back to revisiting what do we need to do at a policy and health systems level across the diseases through entities like that that can bring all the diseases together.
Maybe Susan, I'll just pass it on to you as you know.
Okay. No, thank you very much. So I think one issue that I think is coming up and is this issue of how do we engage in these discussions around transition without letting it distract entirely from the overall health sector reform and development planning that's ongoing. And so I think this goes to the point about the responsibility of the donors in this space and how and how that framing happens. And I think that that is really critical in terms of how things move. And then I also think this issue of being realistic about the role of these investments. And so if you look at, in general, from a financial perspective, a lot of times external assistance is a marginal share of total. But it can be a very large share for specific programs. So if you look at Kenya and Tanzania, it's relatively small total, but for these specific programs. And so there are real challenges associated there. And those challenges involve financial issues, they involve programmatic issues, and they involve political issues. And so engaging in those targeted discussions is really important, and also I think being realistic on what is a government going to be a government issue and what's going to need other actors at the table. And I think this issue on multiple transitions, I mean, you see this in, I mean, Ghana is a country that I'm working in, but DFID is reducing funding, Danita is reducing funding, PEPFAR is reducing funding, Gavi, Global Fund, and this is in a context of a country with a huge fiscal economic, real constraints facing their health budget. And so I do think that there is this issue of that there are, and the space of the Ministry of Health is only so big. And so I think that this multiple transition thing is there in some countries, and then you put IDA and IBRD on top of that. And so some coordination around this overall space is really important. I'm going to pass it off because I think people are more interested in hearing from the Global Fund and the others.
Which seems to be the case sometimes. 3 really quick comments. I think, so first of all, with a disclaimer that I am not involved in the day-to-day procurement efforts at the Global Fund. I think the way I would answer the question is, we do see trends in procurement across the entire Global Fund portfolio. This conversation is often talked about in terms of the transition part of the portfolio. And I think that's a bit misleading, because in many places where the Global Fund is actually transitioning, this is places where countries have taken up procurement a long time before, and where the primary financing of the Global Fund is on things like services for key and vulnerable populations. What I think I would say is, though, this is a pretty complicated discussion across the portfolio about and it really is about the resource envelope that countries have, both from the Global Fund, from other donors, and from their own resources. And as Kirsten, as you know, and I think as many people do, this is a complicated discussion back and forth between a CCM, which is a multi-stakeholder group, and the Global Fund about what do we finance with that resource allocation. And so clearly at the portfolio level, each time a country says, we want you to finance this and we will finance that, the Global Fund looks at the risks around that. They look at whether that makes sense, how that's going to affect coverage rates. And I think what we need to recognize is that often when we're talking about procurement trends, we have a limited resource envelope, both with domestic funds and with Global Fund funds. And sometimes countries are actually saying to the Global Fund, can you please pick up MDR-TB, because that's really expensive, and recognizing that we have a resource envelope, we're going to pick up first-line drugs. And so there's this complicated back and forth discussion that is a really robust discussion at the individual portfolio level. Two more comments, I think, on the multiple transitions. I think it's clear that multiple transitions are happening in some places. I tend to think the discussion, though, is not always that helpful. And the reason the discussion is not always that helpful is because multiple transitions is a nice buzzword, but it's hard to think about if you don't open the hood and then actually ask where it's happening. A perfect example of this, and this is what I think Santiago is getting at, is Gavi has what, 50 eligible countries? 54 eligible countries? The Global Fund has more than 100. The vast majority of the places that the Global Fund is transitioning, Gavi doesn't even they're not even eligible. So where we do see important questions around multiple transitions is where Global Fund allocations are going down and when other donors are transitioning. Now that is a really important discussion, and what that I think should push us all to do is have real advanced discussions up front as early as possible about how a country deals with this. And then I think the final question to the person from Results UK, there are good global forums for keeping this discussion going. I think the thing that I would stress is it really behooves us, particularly folks like the Global Fund, to try to push this discussion to the country level and to really try to foster embedding discussions around planning for transition in the institutions, in the ministries, in the CCMs, in the actors, in the civil society that exist at the country level. Because the more we can do that, and the more we can start the conversation early, the more we're going to be able to plan for something which is absolutely going to be challenging.
Thank you, Matt. So last but not least, Rico.
Yeah, no, so I'll just comment just on one point. I think one thing that we can appreciate from the Global Fund is that the spectrum of how Global Fund engages with the countries are becoming broader nowadays. And I think it needs to continue to be broader, because when we started, like in 2000, well, back 10 years ago, 12 years ago, there's only one way to engage with the country. It's actually through country grants. But then, you know, there's a need for multi-country grants. Now we have multi-country grants. Now we also have catalytic funding, we have strategic initiatives, we have matching grants. So we started to differentiate how we actually work with the countries depending on their context and their needs. And this is the thing about transition, right? And this is how we actually go beyond the zero-sum conversation, because 500,000 for civil society advocacy means very different than for procurement. 500,000 for advocacy can go really, really long. So if we continue to actually expand that spectrum of how Global Fund engage, or in this case, in how donor actually engage with the countries, then we'll probably find a better way to actually support countries while we're using effectively the current resources that we have. So I'll just stop there. Thanks.
Thank you so much. So I don't want to actually even attempt here now to conclude and actually touch upon the many issues we have touched, actually, I mean, to summarize the many issues we have touched upon. I do want to thank you all, though, that you have borne with us, what do we say? Borne with us until this very end. I should also announce that for those, because we are now a bit of a diminished group, if you do want, have a look downstairs whether there are still some sandwiches, so please serve yourself as you go out. I do want to thank also all the partners who have been involved, again, STOPAIDS Alliance and David for organizing that. I do want to thank all the panelists here. Thank you also for that enriching discussion, indeed, for you all to come. And obviously what you can see there, we started with transition towards UHC. We ended up, I think, with many more issues than that. It's not just the financial transition, there are so many more. There's a political transition, there is a leadership, a governance transition, there's a cultural transition. So we didn't touch it at all. So it's like you open up a Pandora box, and there we are, so more discussions to have, and I hope we will have them at some point. Thank you so much for all you to come. Thank you.